Okay, well, welcome back. I hope you had a good break. I heard a lot of interesting comments and questions, and I see that we're getting a lot of questions for the doctors. Thank you so much for being so engaged. There's a lot of practitioners in the house, and their hearts are just breaking. There's a lot of insights that are being shared, and I really appreciate that. I want to remind you that we are global, and if you have colleagues, friends, family members who want to join the discussion, look us up, AIM Youth Mental Health, on Instagram, Facebook, and Twitter. You'll find a link. You can just click it, and we're going live, and then we'll segment those presentations for future rebroadcasting. So if you have loved ones, friends, families, colleagues who can't make it here today and can't pick up the live feed, you're still in luck. Keep those questions coming. I'd like to introduce our next speaker, Dr. Ed Craighead. Dr. Craighead is the J. Rex Fuqua Endowed Chair, Director and Vice Chair of Child, Adolescent, and Young Adult Programs, and a professor in the Department of Psychiatry and Behavioral Sciences at Emory University. Dr. Craighead's research focuses on mood disorders, such as depression and bipolar disorder, and is focused on investigating patterns of neural networks, those neuron superhighways, and genetics, to predict which therapies will be most successful in patients. His work also focuses on the prevention of first episodes in depression. Dr. Craighead's wife, Linda Craighead, who joins us here today, and his esteemed colleague, Dr. David Miklowitz, who you will hear from later in the program, just recently published the 3rd edition of their graduate-level psychopathology book. It is my great honor to introduce Dr. Ed Craighead.
Thank you very much. It's been a genuine pleasure to be here. AIM has done a wonderful job of putting together a group of people, and we've spent the last 2 days discussing new directions and strategic aims. And what I'm going to present today is some work that we've been doing along with a lot of other people that focuses on adolescent depression. So I have to do this for my university. It doesn't mean anything, but it tells you everywhere that I get funded, and it's required for every presentation. I would just call your attention that it includes the Scientific Advisory Board of AIM, which is why we're here. I am an administrator. I'm a clinician. I've seen about 5,000 patients over the last several years with mood disorders, a lot with Dr. Miklowitz, as was mentioned earlier when we were together at the University of Colorado. I now run an outpatient program. So for those who are clinicians here, we see patients every day. I continue to see them myself, and I'll use some of those examples, but today I'm going to focus on sort of adolescent depression, why it's such a big problem, sort of what we can do to improve treatments along the lines of what AIM is trying to do. And I'm going to talk some about the prevention of the initial episode of depression, where I think there's an enormous payoff, because if you don't have the first episode, especially as a young person, you're much less likely to have a future episode. And depression, if you do have an episode, works the other way. So as you'll see, there's about a 20% probability of a first episode, but that goes up to 50% after the first episode for a second. And after the second goes up to about 70-75%. So it's really important that we make early interventions either to prevent the first episode for those who are at risk, or to treat people early in life so that we can decrease the probability of the long-term sort of negative effects of depression. If we look at a recent report by the Pew Charitable Trust, this was only 2 months ago, of 10,000 youth in the United States, 10,000 high school children. And what you can see, they rated what's the biggest concern for their fears. I think this may be a little hard to read, but at the top of the list, and what 70% of the people said was the number one concern of teenagers in the U.S., it was anxiety and depression. That doesn't mean that 20% of the people have anxiety and depression, but rather that they said 70% of the people, this is the number one concern they have. Just quickly, bullying is the second on the list now. So we're going to focus in today, we just had a speech about anxiety, and I'm going to talk about mood disorders. This develops out of psychological stress, and this is an interesting finding that was just published last week, actually, by a group at Florida State with a group nationally. And this is the frequency with which you have experienced psychological distress during the past month. And it covers a period of time going from 2013 through 2019. And what you can see is that for those of you who are between 35 and 40, well, there's a little increase, but it's essentially flat over this 6-7 year period. For those of us who are over 50, if anything, it's at least as good as it's been. But for people who are under 25, you can see that starting in 2013 or 14, if you ask, have you experienced psychological distress in the last month, there's a really substantial uptick in that. And what I'll be presenting argues that that uptick is associated not only with just the stress that you experience, but an actual increase in anxiety and depression. And related to that, an increase in suicide attempts. So what are we talking about? This looks like a little complicated slide, but it's actually quite simple. This is how you get diagnosed with depression. So the rest of the talk will be about this disorder, and it says you either have to be sad, dysphoric, that you're sort of feeling down, but it has to be at a fairly strong level. And if you have that, then you can have at least 4 of these things in addition, such as you're fatigued, you have difficulty concentrating, you have difficulty paying attention, etc. If you also have something called anhedonia, which is a loss of interest or pleasure in what's happening in your life, and you have dysphoria, then you only need to have 3 of these. They have to interfere with your life. Almost everybody has some down days. But in this case, you have to be experiencing these symptoms for 2 weeks, and it has to interfere with your life. What do we have in terms of our population? What are the numbers and who's experiencing this, and when does it happen in life? And this is a very, I think, interesting slide following on what you were just presented about anxiety. You can see with depression, that doesn't happen very often down here, 1-2% in children. It does happen, but it doesn't happen very often. But when you reach 14, you see this dramatic upturn. So I would just call your attention first to the red line. This is a combination of boys and girls. And you can see that it goes from about 1 to 2% at age 14 to about 15% by age 18. But what happens dramatically around 14, but now there just was a new study published from the University of Wisconsin suggesting maybe over the last 5 years, it's a little earlier, that boys and girls begin to separate. And you can see that a little bit on this slide. Dr. Abramson at Wisconsin has found that the difference of depression among girls or females versus boys or males is essentially doubled. So that for the rest of life, the ratio of depression is twice as high among women as it is among men. This is another slide just showing what's happened in terms of the increase of depression over the years from 2011 to 2019. And you can look at the ones that are most severe. These are the people that are likely to be suicidal. And you can see that that's been increasing just slightly every year. So we're really dealing with an epidemic. And one of the major things this is related to is the increase in suicidality. So if this slide shows you across the last decade or so of admissions to emergency rooms for adolescents. And what you can see on the dark line at the bottom is that the number of admissions due to regular health issues in emergency rooms has stayed essentially flat. But if you look at the yellow line of the number of people who come to our emergency rooms, which I would say are very ill-equipped to deal with adolescent depression, you can see that that's had a very dramatic upturn, and only a small portion of this variance is accounted for by the increase in issues with substance abuse, although it's certainly a a substantial contributor. It's most strongly related to the uptick in mood disorders, and it's much higher among youth who are depressed. And as we'll see, 50% of the people who are depressed are also anxious. But the biggest proportion Dr. Miklowitz will be talking about is actually among bipolar disorders, which is by a magnitude of 150% greater in terms of actual suicide attempts. So what are some things that we know at this point? Nearly 20% of teens have had or currently have a major depressive episode. If you just look around the room and the people around you, that means 1 out of every 5 people sitting here has experienced a major depressive episode. And remember, this is not like a month of distress, but actually meeting the criteria for a depressive episode. Something I didn't talk about but want to call your attention to is that in a really excellent study of about 2,000 adolescents in Oregon, they followed them for 10 years, from the time they were teens until the late 20s. And of those who did not get treatment or a prevention program, 73% had actually had a second episode by the time they were approximately 27 or 28. Suicide is the second leading cause of death among teenagers following automobile accidents, and is strongly related to mood disorders, as I just alluded. Only 30% of the people who have depression will get treated. Dr. Clark will probably come back to this because it was about the same percent, more or less, when he started his work in England. But this is our current state. Only about 30% of the people who have major depression, the really clinical depression and who have interference with their life and quality of life and family life, actually get treated. More alarming is that only 10%, perhaps even slightly less, receive an evidence-based treatment, meaning that there is a scientific foundation for what's happening. So you may walk down the street and see a sign for a therapist. You may be treated by a pediatrician. My son's a pediatrician, and we frequently have discussions about who are the right people for him to treat in his practice, because that's where 75% of the people who have depression get their first treatment, from a general practitioner or from a pediatrician. So the question then is, what can we do? And I think that we will talk about 2 or 3 things that we can do. The first is to prevent the first episode among teens. The second is to treat with evidence-based interventions, whether it be medication or whether it be psychosocial interventions. And we need to understand the mechanisms of a therapeutic change so that we can personalize treatment. So, for example, most of the people now who are depressed, even among teens with the so-called black box label, if you don't know what that means, several years ago, it was found, or at least concerned, that taking certain antidepressants increased the suicidal ideation, if not suicidal attempts, among teenagers. So there's a label in the actual medical box warning about that possibility occurring. It's a controversial point, but we in fact need to see what we can do to individualize the treatment rather than just walking into a door and not knowing what it is that's going to happen while you're there. And then that will, in keeping with one of the major things of AIM, guide the dissemination of treatment. So quickly, I'd like to describe for you a couple of projects that we've done. The first in Iceland, the second in Portugal, and we've just replicated the study in Greece, and we're starting this week to actually do it in a portion of Sweden. And the idea is this, that we identify the children who are at risk for major depression. We do that by screening in the schools. So we take certain school districts. For example, if we were to do something like this in Monterey County, we would find the schools that would agree to participate. So we did this in central Portugal near Coimbra because we had some friends there who were interested in doing this. We went to 36 schools. We screened about 3,000 people with self-reports of depression. Those who met certain criteria, we then interviewed to make sure they had not already had a depression. And then we had developed a manual for the students and a manual for the school counselors. So we use the people who actually worked in the schools, not doctors, not MDs, not PhDs, but they're regular counselors. And they implemented this program over a 14-week period after the school setting. And in Sweden, we're actually working with the schools and the Minister of Health to have the assessment done at the school where all the youth are, and the intervention actually done in the healthcare because they're willing to cooperate. And just real quickly, what was the effect of that? We followed them, in this case, for 2 years. And basically what this says, out of every 100 children that are at risk for depression, they have some symptoms that indicate they're likely to become depressed. If you give them the program and follow them, you can see that nearly 7 times as many people who do not get an intervention develop a depression during the next year as versus those who got the intervention. So in fact, there were 13 of the 100 kids per 100 kids in the assessment program, meaning that they just got the regular treatment. They could go to the doctor. We had ruled out people who already had a depression, and only 2 children out of the approximately 100 who developed an episode of depression. So we were able to reduce it by 6-fold. There are many letters from the parents expressing their appreciation, even though it took a lot of work of going to the schools to convince them to participate in the beginning. And then if we look at Portugal, we followed them for 2 years, and what you can see at the end of 2 years, we'll just skip over to here, is that we had 12 incidences of major depression versus 2 among those people who got the prevention program. And I can tell you that in Thessaloniki, Greece, we've just replicated the same finding. It's a slightly different design, but the main point is that we're able, with this intervention in the school for children who are at risk for being a part of that 18% or so who become depressed, we're able to cut that by 7-fold with this intervention in the school. It's an hour and a half run by the school counselors. It doesn't take a sophisticated level of training, although it takes some particular training. So that's what we know about prevention. There's a similar study, a large study in the US with somewhat similar findings, a little more complicated design, but it seems to be working in different cultures in different places. This is based on something you've heard talked about earlier. Both Dr. Kay and the last speaker mentioned that cognitive behavior therapy, this is sort of a combination of cognitive behavior therapy and a form of behavior therapy. There's really not time to go into details. I'm happy to share those. What about treatment? The biggest treatment program in the U.S. That involved about 400 patients is the teenage depression study. And you can see that this is extremely similar to what happens with anxiety. So you can give fluoxetine, the trade name is Prozac, which was the first approved medication for in modern medicines for antidepressants for teenagers. And for a long time was the only antidepressant in this category of drugs that was approved for teenagers. Or we compared it to cognitive behavior therapy, or the group did. And they combined them, and those are almost identical figures to what you saw earlier for the treatment of anxiety and what then was called the CAM study that was presented just before. But this is just with depressed patients. Now this would be really encouraging except for one thing. These are the people who showed some response. But in fact, the percent who showed remission is down between 40 and 50%, and that's in a really good study. Most of the studies are around 35%, and about 30% for each of the individual treatments. What I mean by that is, if you have a depression, if you show some decrease in your depression state, then you are called a responder. But in order to be completely out of the depression, there's something called remission. And there's a reason that I'll show you in just a moment about why that's really important. And as sad as the story is, with all the advances we've made, our probability with both adolescents and even with adults is that we're only going to get somewhere between 35 and 45% remission with the very best individual treatments. So if you translate that to yourself or to people here or your friends that if you just randomly pick a treatment, you probably only have a 35% success rate in terms of remission. So we have a lot of work to do, and that's what the rest of this is about. So what are the most important findings from this? We can prevent or at least forestall the first episode. The relapse rate is very low among people who remit. So the good news is, if you're in that 35-40% who remit, the probability of a relapse is very low. However, if you're in the group who responds but doesn't remit, less than half of the people actually of those responders do remit, and unfortunately 75% of the people who respond but do not remit actually have a relapse within a year's period of time. So that's led us to ask the question of, are there better treatments, and are there treatments that we can develop from science? I'll just mention that one area that we've had a lot of success with is something called behavioral activation. And you can see from, this is teenagers, from pre-test where this is a very severe level of depression, that we are able to get a fairly dramatic change, but this is one small study. And there is a very good study with adults that shows that this is probably our best choice of treatment in the sense of, especially of disseminating. Dr. Clark may talk about this, but we talked about it yesterday. There are a couple of groups in the world who are disseminating this to low and middle income countries with great success, using essentially high school teachers to do the intervention. However, I want to talk for the last few minutes about some of our current studies that try to identify who will respond to which treatment. We know that depression is common, costly, and debilitating disorder. It's the number 2 disabling disorder in the world at the current moment. And what do we are attempting to predict right now, it's like which doctor you go to will determine how you get treated. We're trying to predict who will respond to which treatment. As you can see, there's essentially no difference. About 35% of people, you look at this square at the bottom, there's no difference of whether you get an antidepressant, a medication, or a psychotherapy. And as my favorite Danish physicist said, prediction's very difficult, especially if it's about the future. And so that's what we've undertaken to do. We've treated 350 patients or so at one setting at Emory, where they got either one of 2 medications, escitalopram, duloxetine. You probably know those as Lexapro or Cymbalta, and compared it to cognitive behavior therapy. So we have 3 treatments in monotherapy. The meds were the same, so we put them together. And if you look at this slide, I don't want you to think for a minute that this is about the details of the neuroscience. But what we found is, for those people who got cognitive behavior therapy, if you look at the side of my head, this is the front and the top, the frontal area, the thinking part, the cognitive part. This is what you just heard about in terms of regulation of mood. And this is actually the area of the brain where mood is involved. And if you want to use a metaphor for this, if you think about it as an expressway, a 4-lane road, a 2-lane road, some of the roads in Carmel that seem to be 1 lane, and then a path, that if you have a strong pattern of connectivity that goes from this area through the part that's regulating your emotional reaction to what's happening in your life, and then to the actual emotion activation system, to some part of the lower brain, which we were very surprised to find. It's the periaqueductal gray for the MDs or the neuroscientists listening are here. If this is connected and there's like a superhighway, you do really well with cognitive behavior therapy. You fall into this group and you're a remitter. But if that's like a little country path, in other words, there's very poor connection between the frontal thinking area and the emotional area and the regulation of emotion, then it's going to take something besides behavior therapy or cognitive behavior therapy. Some of my colleagues don't like for me to present this because my background's in CBT, cognitive behavior therapy. But in fact, if you don't have this pattern of connectivity, I'll show you on the next slide, which is a little complicated, but I'll just call your attention to one part of it. If you look at this, these are the people who have a really strong connection, and they're the people who remit with CBT. And you see virtually nobody is in this group that has a very poor connection. The drug responders are there, and very few of the drug responders have the strong connection. We don't know exactly why the difference, but basically, if you have a strong connection, your probability of remission, remember it's 35% generally, it goes to 70%, it doubles. However, if you are below this line and you receive cognitive therapy, you have a 5% chance of remission. That's why there are so many failures with a particular therapy. That's the therapy side. The converse of that is medications. It's not quite so clear, but if you're below that line, you get about a 55 to 60% chance of remission with meds. But if you're above that line, you get, again, less than 5% with medication. So this is an attempt to differentiate. Now, you're probably not going to run out and get a brain scan when you go to the doctor with depression. But that's becoming much more common, and it costs less than my last physical did by a good amount. It's down to about $400 or $500 if you have insurance. If you don't, it's terribly expensive, which is another issue. But what we're working on now is there a genetic marker which we can identify easily by collecting saliva from you? And this is what we did in the project in Portugal. And you can make the genetic determination from the collection of saliva, which is very stable. And what we were able to do to identify in Portugal was that there are certain genetic markers that predict better who becomes depressed than their report of some symptoms of depression. And what we're collecting now and looking at is, are there genetic markers associated with these brain mechanisms that actually will identify when you go to the doctor, you can spit or they can take blood, and by the next day, the doctor can say to you, this is a pipe dream, but it's still, you have to think this way, that within the next day or 2 days, the doctor can say to you, if you take your genetic type and brain type suggests that you need to get psychotherapy, an effective kind of psychotherapy. And you probably won't respond to meds. And if you are a person who gets started on a meds but have this brain type, you're probably going to fail the first one, which may be sertraline, it may be any of the SSRIs. If it doesn't work on the first one, you're up the dose, and then you go to the next one. So now you go to escitalopram or Lexapro, and then you may ultimately get back to fluoxetine or Prozac. You go through those, and finally, you may give up because the probability of success is so low unless you're matched to the treatment. Conversely, if you go to a therapist who may be extremely well-intentioned, but who is not treating a person with a brain type and a genetic makeup that's responsive to therapy, then you're going to wind up after sometimes after one session, but usually after 7 or 8 sessions, you're going to say enough of this already, and then you're going to wind up going and maybe starting on medication, and that may be appropriate. But the point is that we are making real progress in this area of identifying the subtypes, and the real advantage is your probability of being treated successfully to remission goes from something like 35 or 40% to 70%. And we're doing this with adolescents right now. I don't really have time to talk about it in great detail, but again, it's 40% remission rate, however, and a 90% response rate, but we can get it to 70% for a subset, and this is the current work we're doing, if you have low motivation, something very similar to effort for control that we were talking about earlier. So when you're doing a task that involves reward, as an adolescent, it actually has very little impact, but only on a subset of the depressed people. So for example, people who are anxious and depressed, it seems not to work very well with them, the intervention we're doing of behavioral activation. But if you have people who have very low motivation and have given up, basically, they don't work for money in the laboratory. It's not of interest to them. They're really poor at decision making. And what we've been able to show, because we now are at the point that in sessions 2 and sessions 8, we actually have the adolescent have the therapy occur while they're in the scanner. So we scan them ahead of time to identify the subtypes. The ones that seem appropriate get this particular treatment. If they have low motivation and they're tired, etc. And we actually scan them while they're doing the therapy. And what we've tentatively been able to show is that the people for whom this particular therapy works are the people who make a stronger connectivity between their positive decision making and the activation of reward activity in a certain part of the brain. And the name of that's not so important. Just think of it as the area that Dr. K talked about, we talked about earlier, where reward really activates. It's called a ventral striatum for those interested. And if that connectivity increases with positive decision making and willingness to do the activities in the therapy while they're in the scanner, we actually can see the brain change in the direction that looks like the brains at baseline of normal, healthy children. So I'll just finish with this slide saying, it sort of as a summary, that I was able to find this. I hope it's reasonably accurate. But it also represents almost every state in the U.S. It's certainly true in Georgia, where we do our work. The number's a little low here on the 1 in 13. It's really more like 20 to 25 out of every 100 children. But the next line is really interesting. One of the major players, there are fairly much enough child psychologists and adolescent psychologists and social workers who work in this area, although there's still definitely worker shortfall. But the really serious area is that in California, there's one psychiatrist, child psychiatrist, for every 857,000 people. It's a remarkably strong indicator of what's happened in the past and how much we need to change. Furthermore, just as in Georgia, almost identical percentage, 44 of the 58 counties in California, including Monterey County, San Benito, and Santa Cruz, have no child psychiatrists, they have child psychiatrists, no child adolescent psychiatry beds. Now, the really good news with which I end the talk is that problem is being solved here. It's being solved thanks to the generosity of people of this area, one person in particular, but in fact, that just gets it started. It takes an entire team. And the great news is that you've hired Dr. Swick, who's been visiting with us over the last couple of days, and this situation is being changed in the Monterey Peninsula. And there actually will be a place that you can send a child for psychiatric care for depression and bipolar disorders that's going to be located right in Monterey County. And you don't have to hustle to get down to LA to see Dr. Miklowitz or up to Stanford, as was mentioned earlier. And I think that this brings me back. This brings me back to my concluding point, that it's the generosity of people and people who are willing to take the time and who have the concern, like yourself and the people who are listening via streaming, and the people who've taken the leadership in putting together things like AIM. There are other groups too that's beginning to address this great dearth of treatment, and especially of effective treatments for adolescents, who is so important for us to prevent or intervene early in order to give them a great quality of life that they otherwise will not have. Thank you very much.
Staggering statistics, and yet there's hope right in our community. You don't have to go to a major metropolitan area soon to enjoy all of the spectrum, the full support for child's mental health. Isn't that extraordinary? That's unheard of. So I like to believe that right here in Monterey County, we will be leading those 58 counties in California. And as the saying goes, right? As California goes, so goes the nation. Yes. Our next guest truly underscores the fact that AIM's Scientific Advisory Board is international in scope. We've hand-selected them to represent not only their respective fields, but the global community of practitioners, parents, researchers, teachers that are interested in child well-being and youth mental health. Dr. Professor David Clark holds the chair of experimental psychology at the University of Oxford in London. Dr. Clark is well known for his work on the understanding and treatment of anxiety disorders. Along with his colleagues, he has developed original and effective cognitive behavioral therapies for 4 different anxiety disorders: panic disorder, social anxiety disorder, post-traumatic stress disorder, and health anxiety, commonly known as hypochondrosis. He is the National Clinical and Informatics Advisor for the Improving Access to Psychological Therapies, or IAPT program, and I'll probably be speaking about that this morning. Dr. Clark, along with his colleague Dr. Richard Laird, is the author of Thrive: How Better Mental Health Care Transforms Lives and Saves Money. Please welcome Dr. David M. Clark.
Thank you very much, and it's a real pleasure to be here, really for AIM's event, because AIM exists to fund treatment research which will have a fairly immediate impact on improving mental health. And so I'd like to give you an illustration of the sort of research that can be done, which can use studies understanding what keeps a disorder going in order to improve treatment. I'm going to focus on one of the most common disorders, depression, and is one that you've just heard about from Ed Craighead. The other really common anxiety problem is social anxiety, so that's what I'm going to talk to you about. I'm largely going to focus on research that we developed in adults, but you will see that the story extends into adolescents, and that we've got very promising results, which is why the title of the talk was Promising Results, showing that it can be at least as effective with adolescents, perhaps more so. So to start off with, what is social anxiety disorder? Well, it's a persistent fear of social or performance situations. Mine now is a classic performance situation, public speaking. And if you ask the general public whether they have a fear of public speaking, about 40% of people do. But thankfully there are many more worthwhile things to do in life than be a lecturer. And so if that's your only fear, then you'll probably just go on and do something else. So in the clinics, we don't usually see many people whose fear is only public speaking. They also have a fear of a much wider range of social situations, just talking to people casually, having a cup of coffee, meeting people at a party, that sort of thing. And they have a whole series of fears. Their main fear is that when they're anxious, they will do something which will lead to their embarrassment or humiliation in front of other people. And of course, they try and avoid social situations, but we all have to meet people every day. And so the key feature of this condition is that people are becoming anxious when talking to other people every day of their life, but they're enduring those situations. They're rarely getting very negative feedback from other people, but their fear persists. And that's a real puzzle, because if you're not getting a lot of negative feedback from other people, why don't you realize that you're coming across okay and that you're acceptable? What is it that prevents you from learning that? And we used to have in psychotherapies a one-trick therapy called exposure therapy, which got people to expose themselves more systematically to feared situations. But the problem, of course, with social anxiety is people are doing that all the time in any case, and that naturalistic exposure isn't working very well. So what you've got to do in research is find out, well, why aren't people getting better from their naturalistic experience in social interactions? And I'm a cognitive therapist, so what we say is we need to get into people's heads and understand what they're thinking when they're in a social situation, what they're paying attention to, and also how that affects their behavior. And if we can answer that, we hope we can develop more effective treatments. But before I show you how that's done, I'd like to say a little bit about why social anxiety is such an important clinical problem. So it's the most common of all the anxiety disorders. In US samples, it's estimated that the lifetime risk of social anxiety disorder is about 12%. Of course, many of us get anxious in some social situations, so it's a continuum. But what we're looking at when we're talking about social anxiety disorder is people who are really held back in life because of their social anxiety. There's many things they can't do that they'd really want to do. It typically has a childhood age of onset, so half of the people who you see in adulthood with social anxiety have already developed the problem by the age of 13, and almost all the rest have developed it by the end of adolescence. There are some very nice, quite long-term follow-up studies following people up for at least a decade, and what they find is that although some people recover on their own, about a third of people, then you've got 2/3 of people who don't recover in the absence of treatment. That makes it the most chronic of all the mental health problems. It has the lowest natural recovery rate. Given that, it's really very worrying that it brings with it a markedly increased risk of depression. Many people get depressed because their life isn't progressing the way they want to, and often it's only the depression that the doctors pick up. They fail to spot the social anxiety. It also, of course, for some people can trigger suicide attempts, and for some people they'll use alcohol or street drugs to manage the social anxiety, and that can become a problem itself. It also leads to marked underachievement in life. If you look in the school population and you look at children's IQ, and then you look at the exam results they get, if they have social anxiety, they tend to get less good exam results than you'd expect, given their intelligence. And the reason for that is really simple. They feel incredibly uncomfortable and self-conscious in the classroom, so they find it difficult to concentrate on what the teacher is saying. And so, of course, they benefit less from our existing education system. Once they get into the job market, they find they're much less likely to be promoted at work than other people, because a lot of promotion isn't just how good you are at doing the job, it's also about your social networking, and they find that difficult. They're less likely to get married, they're less likely to have children, they have less people at their funerals. It blights the whole of your life. So it is really something that deserves a lot of attention. What are the sort of thoughts that people have when they're anxious in a social situation? Here's some of the classic ones. People worrying that what I say sounds stupid, I'm boring, I'm going to make a fool of myself, other people don't like me, and then the most common, other people can see I'm anxious. And then if they see you're anxious, what are they going to notice? I'm blushing, I'm sweating, I haven't got anything to say, I'm trembling. So in many ways, social anxiety is a fear of fear, or a fear of other people seeing your fear and then thinking badly of you because of that. So how can we understand why it's so persistent? Well, Adrian Wells, another psychologist, and I interviewed many people with social anxiety in the 1990s, tried to get into their heads and find out what's happening when they're in a social situation. And we noticed three things. Firstly, to do with what people are paying attention to. And although they might be talking to someone else, they would say, my attention isn't really so much on the other person, it's on myself. I'm always watching myself. I'm thinking, how am I coming across to other people? So it's a sort of self-focused, evaluative attention. And that's a problem in its own right, because if you're talking to someone and the conversation goes reasonably well, but you're lost in your head like this, you won't notice it. So you won't notice how things are going. And that's probably why exposure therapy alone does least well in social anxiety, the different anxiety conditions, particularly in children. But once you're focusing attention on yourself, it's worse than that, because as you focus on yourself, you become aware of what we call internal information. So information in yourself, which you take as very good evidence for your negative fears, but it isn't actually, it's very misleading. So I said the most common fear is that other people can see you're anxious. So of course we asked all the patients, well, what makes you think that? And we were really shocked to find that most people said, well, no one has actually said that. So we then said, well, if no one said that to you, what makes you think that you look so anxious? And they said, well, I feel very anxious. And if I feel very anxious, I must look very anxious. So they're using their feelings to decide how they appear. Sounds a logical strategy, doesn't it? But there's lots of research that shows it's very misleading. It turns out that the more anxious we feel inside, the more we overestimate how anxious we look to other people. So it's not as though people with social anxiety don't look somewhat anxious and inhibited, but if you get into their heads and find out how bad they think that looks to other people, it is much more extreme than what you and I see in front of us. And that difference is encapsulated in another bit of internal information, which is mental images. In anxiety, a lot of the thinking is in pictures, it's images. And in social anxiety, the images have a particular quality. People tend to see themselves from an observer's perspective. It's as though there's a camera looking down at them and they see themselves from some other person's perspective. But unfortunately, what they see is not the way they really look to you or I, but rather their worst fears visualized. So one of my recent patients was a very young teacher. She was just starting her job at school, and she was very worried when she had the morning coffee break, meeting the other teachers, that if she spoke, they would think she was very stupid. And so she rarely would speak, but when she started to speak, she'd feel tension around her lips. And that tension around her lips would be transformed into a visual image in which she would see herself looking like this. And when I asked her, well, what does that look like to you? She said, the village idiot. So she didn't need to check out from other people how she was coming across. She knew she looked stupid because she could see it in her mind's eye. But of course it was misleading. The other thing that people do is what we call safety behaviors. So we all do safety behaviors. So safety behavior is something you do to try and prevent something bad from happening. So if you think it's going to pour with rain tomorrow afternoon, which the Monterey forecast says it is, you might, if you leave the home, put on a rain jacket, and that's going to prevent you from getting soaked. And there's really nothing wrong with that. Safety behaviors are all fine if the thing you're worried about is a realistic concern. But if the thing you're worried about is not a realistic concern, it's to do with people thinking very badly of you when they're actually unlikely to think that of you, then doing the safety behavior prevents you from correcting your beliefs. It prevents you from discovering that things are not as bad as you think. And in all anxiety disorders, we find that many people do safety behaviors, and that's one reason why they don't correct and get better without therapy. So in social anxiety, some of them are obvious things. So if you're worried about blushing and you're talking to someone else and you feel a bit hot in your face, then you might put your hands over your face like that so people won't notice. Or you might just move in the party into the dark shade so that people don't notice. But often these things are things that people are doing in their head. And so unless you're in therapy, it's difficult to spot them. So this teacher, for example, if she summons up her courage to talk to her colleagues, while she's talking to them, she will memorize everything she's already said to them and compare it with what she's about to say in order to check it's clever enough. And she'll often decide it's not, and so she won't say something. So what's the consequence of that? Well, if things go okay, afterwards she'll be able to think to herself, it's only because I did all that memorizing and watched myself carefully. If I'd just spoken naturally, people would think I was stupid. So her basic fear persists. But it is worse than that, because if you were talking to her, she, of course, really wants you to like her. She wants to get on with you. But she will give you the opposite impression. She will appear as though her mind's somewhere else, which it is. It's on this memorizing. And she will appear as though she's not interested in you. And mostly, out of respect, if someone doesn't seem to want to talk, we don't talk back to them. So here is a sad example where the thing someone's doing to control their anxiety is actually interfering with the social anxiety in social interaction and making people actually be less friendly to her. Not because they don't like her, but because they're respecting the cues she's inadvertently giving off. So that's the sort of thing that happens in social anxiety, and there are lots of experimental studies that have been used to test this theory, and in general they've provided very strong support. There are about 100 experiments testing different aspects of it. I don't really have time to go through all of those, but I'd like to just show you one illustration of how it all fits together. So this is a study we did where we got people with social anxiety to have a conversation with a stranger. And during that conversation, we got them to just flip in their head between the normal, very negative, distorted images they tend to have of themselves, and then to a more positive, more realistic image. The person they're talking to has no idea what this experiment is about. The first thing that you notice when we look at the results is that if you're holding the negative image in mind, which is the blue bars, then you feel more anxious than if you are holding the positive image in mind. You also think, this is your measure of your own performance, that you came across less well when you're holding the negative image in mind than the positive one. That's an excessively negative evaluation of yourself, because if we look at the other person's rating of you, you see they rate you much more positive on both occasions. But there is something interesting here. There is a small but highly significant effect that if you've got your normal negative image in your mind, then the other person rates you less positively and is more likely to say, I don't want to meet you again. So this is like magic, isn't it? You're just flipping an image in your head and it's changing the other person's liking of you and their responses to you. So how come? How's that working? Well, the answer is here, what we call the safety behaviors. So when you turn on these negative images of yourself, it then rather automatically also turns on these safety behaviors, this internal monitoring, and also staying on the edge of conversations and things. And we think it's that other people are noticing and reacting less positively. So you see, it's a very tight loop of changes in thinking, in imagery, attention and behavior that all interlock. So of course what you have to do in therapy is break that interlock. What we've done is developed a therapy that really just focuses on each of those processes and tries to change them. It starts by just working out with the patient how all these processes fit together, developing a model with them, and then we go on to actually help them discover the adverse effects of focusing attention on yourself and doing these mental operations by getting them to have two conversations with a stranger, once while focusing on themselves and doing the mental operations, and the other time trying to be rather more externally focused, just going with the flow of the conversation, which is not what they normally do, of course. And it's a shock, because what they discover is that their strategies that they've been using so far to manage social anxiety, focusing on themselves and doing all their safety behaviors, are not actually part of the solution. They're not actually helping. They're actually making them feel more anxious, because when they focus externally and drop the safety behaviors, they feel much more comfortable. Of course, this is a great discovery, because it makes people think, oh, this therapy's got something for me, something that'll help me feel more comfortable in social situations. So it's a great way to start. But what we then do is look at these very distorted images people have. And you could, as a therapist, just give people feedback and say, well, actually, you didn't come across anywhere near as badly as you thought you did. And that's okay, but a lot of people won't believe that. They'll think, well, therapists are paid to say things like that. They're nice people. So it's much better if people can see it with their own eyes. And so we use video feedback for that. So we video the social interactions. We get people to predict how they think they're going to appear, and then we show them the video. And when set up carefully, that's a very therapeutic experience, and people realize these images are very distorted. They don't come across like that. So then the next phase of therapy is to retrain people's attention. So to train them how to become more externally focused in social interactions, less lost in their head, just monitoring themselves, but rather just going with the flow of the conversation. And once we've done that, we then, essentially, the rest of therapy involves getting people to do experiments in social interactions where they test out their negative beliefs about how they come across to other people by engaging more in social situations, but dropping those safety behaviors. So this teacher, she would be encouraged, while she's talking to other people, not to be monitoring herself, not to be remembering what she said, just going with the flow of the conversation. And when she did that, of course, she found that people were actually pretty interested in what she was saying, and she was very accepted. So the key goal here is to help people discover that they're acceptable as they are. They don't need to be using lots of clever strategies or relaxation to manage their anxiety. If they just let the world know them, they will be accepted. But the problem is in social anxiety that people in general not letting the world know them. Of course, some people have had some traumatic experiences early in life linked to the development of social anxiety. So we also use some techniques from the PTSD treatment to deal with early traumatic memories. So that's the treatment as used in adults. When you're applying it to adolescents, do you need to change it a bit? The core techniques all seem to apply, but we add a few extra things. The first is, of course, you're living in a family context, and families care enormously about being helpful, but sometimes their own beliefs, one way or another, sort of hold children back a bit in therapy. And so we look at parental attitudes. Some parents really, as their child finds some interactions very difficult, will then say, well, let's not bother to go there, let's not do that. So they're encouraging avoidance, and that is preventing some of the key learning. Some others are really very pushy, saying, no, you've got to get up in front of the audience and you've got to sing that solo. That's what everyone who's successful in Carmel does. I'm not sure that's really true, but, that isn't therapeutic either. And so there's a middle ground, and we work with people to discover that middle ground. Of course, for adolescents, you can find yourself the subject of bullying at schools, so you need an intervention which also works with the schools to deal with that, but also works with the children to look at the dynamics of what's going on in bullying. And a lot of children who find themselves bullied also feel that the bullies are the people who determine their worth. And so if they could be friends with the bullies, what we call beg friends, then that would be very important. And it's really to help them see, no, the police are not the arbiters of people's worth. They're the people with problems themselves. And get the children to look around, perhaps the quieter people in the class, and start developing relationships with them that are much more empowering. So that's the sort of overview. Does the treatment work? Well, for the adult version, it has been tested quite a lot in different European studies. There are 7 clinical trials, and it's always been compared against a good competitor because, of course, what you're trying to do with research is improve things. And it has always beaten whatever it's put up against. So we have a trial comparing it with exposure therapy, where it did substantially better, group cognitive behavior therapy, which used to be the gold standard, interpersonal psychotherapy, psychodynamic psychotherapy, and the optimal medications. Actually, it's the same one that Ed was talking about, fluoxetine. And this just gives you an idea of the sort of effects you can get. So this is a cohort of patients in our last clinical trial. We're just writing it up at the moment. There are about 100 patients, and this is how severe their social anxiety is before the start of treatment. This is a scale. As you go more to the right, the more severe the anxiety is, and this is how many people in that category. So the clinical, non-clinical cutoff is here, so everyone's in the clinical range. But you see they vary. There are a few people who are mild, but most of them are moderate or very severe. What I'd like to show you now is what happens to people's scores, the whole distribution, everyone in that sample, when they've gone through a course of cognitive therapy and we followed them up a year later. Why do I say following up a year later? For a chronic condition such as social anxiety, it's just not okay just to get someone better. You have to keep them well to transform their life. And you can see the distribution has moved massively into the non-clinical range. In this particular study, we have 76% of people who are fully recovered and 90% of people who are what you call responders. But we don't have any treatments that work for everyone. And you can see we've got 3 people here, very severe, who we didn't do anything useful for. So there's more work to be done. But these are sort of potent results in adults. What about in children? Well, we've just started working on that. I have a very good clinical psychologist, Eleanor Lee, who works on this. And this was her first sort of exploratory work, taking a group of 5 very severe children with social anxiety, most of whom were also school refusers, so they weren't regularly going to school. And this is the severity of their social anxiety at the beginning of treatment and at the end. You can see they all show big drops, actually a bit bigger than the average we get with adults. What about what's happening to them in the classroom? So you remember I said that people find it very difficult to concentrate in the classroom, and that affects their exam results. So does this treatment help with that? And so, of course, we got the children to rate the extent to which they could concentrate on what people were saying in the classroom, and in particular what their teacher was saying. And you can see really very marked improvements. The blue is the pre-treatment level, the orange is the post-treatment, and the green is 1-year follow-up. And you can see really very big improvements in concentration. All of the children got back into school, and 2 of them, the older ones, are now studying at a very prestigious English university that I shouldn't mention by name. So these treatments can be very powerful. Of course, you want to get them to the maximum number of people, and one of the big developments in psychotherapy research is using digital things to help with that. And so we have now developed an online version of this treatment where a lot of the learning you do not in a face-to-face session with your therapist, but at home in your bedroom, where you get taken through many of the key techniques and then encouraged to try them out in school and in your workplace as social interactions. You still have a therapist, but they're supporting you largely remotely by messaging, and there is a video component in it as well. So you can do the video feedback that we talked about online. You can have a conversation with someone, it records both ends, and you can make your predictions and see how you do. So this sort of saves about 80% of therapists' time. So you could, in principle, treat 5 times more people. And here's a recent trial we've just finished on that, comparing people who have the face-to-face normal therapy over 3 months, 21 hours in total, or the internet treatment with only 4 hours of therapist assistance. And this is a group who had no treatment or waitlist. And you can see the internet treatment is doing essentially as well. There are other ways in which digital things are helping. One of the nice things for fear is virtual reality, where you can get people to explore the situations they find fear-evoking in a virtual world and then see, doing all the maneuvers you do in therapy, does that transfer to the real world? And I'd like to finish up by talking about another group of people in whom social fears hold them back in life, but it's not people who, in the sort of psychiatric jargon, we'd say primarily have social anxiety disorder. This is people who have paranoid psychosis. So they have schizophrenia and they have particular beliefs. They think if they leave the house, someone will kill them. Well, if you have that belief, you're not very likely to turn up to therapy, are you? Because you might get killed on the way. But what we've been doing is using virtual reality to get them to explore the sort of situations they'll avoid, traveling on public transport, being in a big shopping mall and things. And when they're in that virtual world, doing a lot of the therapy maneuvers we do in real life. And here's a sort of illustration of it. So here's the patient with the virtual headset on, and this is what he's seeing on the right-hand side. This is a a London Underground train. And then this is a sort of crowded workplace and going into a shopping mall. And so our first study of this was a sort of tight experimental study. We gave people with paranoid psychosis just one session, a 3-hour session, exploring the virtual world. Before that, we tried to get them to go out, and we measured their fear. And then afterwards, we got them to go out. And you can see there's a very big reduction in their fear in the real world. So you get an extraordinary transfer to the real world. This is now being scaled up in a current research project to a full-scale treatment. It'll be 6 sessions. And we're very enthusiastic about the possibility here of really dealing with people who are very disabled because of psychosis, but in whom the issue is still the same, generating the disability, which is actually the social anxiety component. So I'd like to sort of round up now and just say, hopefully this gives you a taste for the sort of research that can be done to improve treatments, and it's exactly the sort of research that AIM focuses on. AIM is a pretty unique organization in having its idea that it's research that will have an impact now. So looking at research that will translate very quickly into interventions. And it's something that we need so much more of, because mental health research in every country, and the US is definitely an example of this, is the poor sibling. We get much less investment in it than physical health, despite the fact that it is incredibly disabling. Thank you very much.
Our final presenter, before we get on with the panel, we'll take a break between those two, is Dr. David Miklowitz. Dr. Miklowitz is a professor of psychiatry in the Division of Child and Adolescent Psychiatry at the UCA Semel Institute and a senior clinical research fellow in the Department of Psychiatry at Oxford University. Dr. Miklowitz's research focuses on family environmental factors and psychoeducational treatments for children and adults with bipolar disorder. His work has helped establish the effectiveness of psychosocial interventions in the treatment of bipolar disorder. Please welcome Dr. David Miklowitz.
Good morning, everybody. It's a real pleasure to be here, and I'd like to thank Susan Stillwell for inviting me and for the chance to be part of the Scientific Advisory Board of AIM. I'm also one of the recent recipients of the postdoctoral awards. I have a postdoc named Mark Weintraub, quite a talented guy, who received 2 years of funding from AIM to do some work on prodromal forms of schizophrenia, which I'll be talking about briefly, and also some work on internet-based therapy, which Dr. Clark touched on. So, but what I'd like to talk about is something that I think is strongly affected, families are strongly affected by, which is having a son or a daughter who has bipolar disorder. And that's been my focus for most of my career. What should families do when they have a bipolar offspring, or if it's an older person, a bipolar spouse? What are the good ways to cope? What are good ways for the person with the disorder to cope and communicate with their families? How do people know when that person is getting ill? What can they do as a family to make the course of illness go better? So, illness. What I'd like to do in the half hour or 25 minutes that I have is to go over with you what are the symptoms of bipolar disorder, how do we distinguish it, for example, from depression, what is our treatment, what is family-focused therapy, which involves all family members in an outpatient protocol, often during or after a hospitalization. What are some illness management strategies? Some taken from cognitive behavioral therapy, some taken from other forms of therapy. How do you deal with medication non-adherence? We have some great medications for bipolar disorder, but people are loath to take them because they have side effects and there are worries about the long-term effects of those medications. What's the role of marijuana use? Do people self-medicate with marijuana? Is that a good thing to do? Where is weed in the whole pharmaceutical array that we have available to us? Side issue I think I'll spend a couple minutes on is the distinction between bipolar disorder and borderline personality. How many of you have heard the term borderline personality disorder? Okay, you may find it's confusing when you're trying to distinguish it from something like bipolar disorder, which is also a disorder of mood, reactivity, explosive affect, unstable living situations, unstable interpersonal circumstances. I'll tell you a little bit about how I think they're similar and different, as well as ADHD. That's the classic question that comes up for kids. Is this bipolar disorder? Is this attention deficit disorder? After all, they both involve hyperactive behavior. Finally, I'd like to end up by talking about the one positive dimension of bipolar disorder, which is the link with creativity, which we know to be true under certain circumstances, that people with bipolar disorder do tend to be on the creative side, musically, artistically, in terms of writing, and also their families tend to be. So we suspect there are genetic connections between creativity and bipolar disorder, but I'll also tell you what some of the limits of that finding are. So usually when we talk about families in the psychiatric literature, particularly for disorder like bipolar, we're usually talking about family trees. And people say, okay, well, this is a bipolar person because bipolar runs in her family. And this is a typical family. We have a young adult named Nancy, who's been diagnosed with bipolar 1. She has a sibling that's healthy, another sibling with possible substance abuse, biological mother with major depression, mother's brother has alcoholism, mom's mother died at 78 with a possible depression, father's okay, mom died, dad's mother died healthy, his father died of a neurological illness, dad is healthy. Now, as you can see, not everybody in the family tree has a disorder, and she's the only one who actually we know for sure has bipolar disorder. We suspect that mom's brother may have bipolar disorder, but we're not sure. But in fact, this is the way the genetics of this disorder tend to go. We see family pedigrees that are dotted with not only bipolar disorder, but depression, substance abuse, and in some cases eating disorders as well. They carry the feature of emotional mood dysregulation, which is probably what the genetics of this disorder refer to as opposed to just inheriting the condition one-to-one. Many parents ask me, what are the risks if my husband has bipolar disorder? What are the risks that my child will get it? And usually that the averages are about 10 to 15%. So they're actually fairly low, although the reputation is that it's a highly genetic illness. So we have to keep in mind that there's a genetic background as well as a social background that has to do with how does that family interact. How does bipolar disorder affect the family? Well, in a million ways. You can have a teenager, for example, who gets bipolar disorder at age 14 or 15. Let's say it's a depression, but then it gets followed by a hypomanic or a manic episode. Hypomanias are less damaging forms of bipolar disorder, where the kid may be charged up in energy or elated or full of grandiose ideas, not sleeping a whole lot, but it's just not that dysfunctional. The kid can still function on a day-to-day basis, as opposed to mania, where you can have those same features, but the kid is not able to function, not able to go to school, gets picked up by the police, disappears for periods of time. When a kid is going through these episodes, you get a lot of hostility being expressed between the teen and parents, intensive periods of family conflict, which of course don't tend to help anybody. Sometimes during the depressive phases, the teen will self-isolate, and that's when you start worrying about suicide, or they leave suicide notes, or they talk about thinking about it a lot, or they're just shut off, and you start suspecting social anxiety, but it may also be depression and social withdrawal. All of this affects parents the most. They become exhausted, they become burdened, frustrated, marital problems erupt, trying to take care of this kid. A very neglected area is what about the siblings, because the siblings often are suffering on a day-to-day basis because the brother or sister, not only do they get all the parents' attention because of their problems, but in addition to that, they may have their own genetic vulnerability or their own mood problems and start imitating the larger sibling. All of this is complicated by the stigma that families feel. And actually, it's my hope that groups like AIM will help with stigma in our society. People still are not willing to talk about it. Communities still don't talk about mental illness, particularly in kids. It's kind of off limits for conversation, even though we know that many, many families in a community like this are dealing with these disorders in their kids. And the families tend to feel very isolated when they're not encountering other families with the same problems. This cartoon was given to me years ago by a parent of a 16-year-old with bipolar disorder, and her comment to me was, "You've been asking me what it's like to be a parent of a teenager with bipolar disorder. That's me on that string. My son is like a big baby puppeteer, keeping us all on a string with his vicious mood swings. And worst of all, he seems delighted that he can do it." So there is a feeling many family members have of being disempowered, that the kid has kind of taken over the family atmosphere and that everybody's tiptoeing around the child to make sure they're happy and aren't going to have a blow up in some way. This is where siblings become most resentful because they think that their older sibling is being coddled, but it can be a very difficult string to be carried around on. What do we do in family-focused therapy? First, this is a treatment that usually starts after a manic or depressive episode. So after one of these phases where someone is elated, grandiose, has a decreased need for sleep, they're sleeping 3-4 hours a night or not at all, their thoughts are going very fast, they're speaking very fast, they sometimes eventually end up in the hospital, and after the hospitalization, they need to recover. They need to recover in a safe environment, hopefully one that's low in conflict. We know that if the family environment is low in conflict, that the recovery will be more smooth and more rapid. But how do you keep the family low in conflict when someone is still very symptomatic, might still be suicidal? That's the population we target with these treatments. Our typical treatment is 12 sessions long on an outpatient basis. The first segment we call psychoeducation. Not quite the same thing as education. Education is where you sit down and teach people about bipolar disorder and what it is and its signs and symptoms. This is more of a Socratic discussion with people in terms of what they've gone through during the episode. So we say to the kid, you're the expert on this because you're the one who's gone through a manic episode. Can you describe to us what it's like? If the kid doesn't want to talk, then we have a handout which lists some of the symptoms. Well, have you ever had any of these? Have you ever had elated mood? Have you ever had hypersexuality? Have you ever had being full of energy? And you get them talking, get the parents to chime in. Well, I saw you doing this. I saw you getting up super early in the morning. There was one day you were waving at airplanes thinking they could see you. You were watching TV trying to see when your name was going to be called. These sorts of things get brought out and defined as an episode. Until you get everybody on the same page, this is what the disorder is, and this is what it isn't. Now, I'm oversimplifying. Lots of things can happen during those psychoeducation sessions. So, for example, a patient may say, I've always been this way. This is my personality. I've always been hyper. I've always been driven, achievement-oriented, and now they're just calling me mania. They're calling me manic because they want to put me in a cell somewhere. The parents sometimes over-identify with the label and say, no, you've got to take these medications, you've got to make sure you keep a very strict sleep-wake cycle, all of which may be true, but it tends to create this resistance in the adolescent. Now, what we hope to come out of this phase of psychoeducation with is what we call relapse prevention plan. So the family comes up with a series of strategies to use when their teen has the next bout of prodromal symptoms. And by prodromal, I mean the symptoms that anticipate the onset of mania or depression. So the next time they start showing decreased sleep, or they become more irritable, or they start talking very fast, that's when we want the family to intervene, either by creating some more structure in the environment, calling the doctor in perhaps, having another therapy session, having a family discussion about how they want to handle it this time, collecting more information from other people about whether this is truly an episode. There are various ways in which the family can curtail the impact of that episode. They may not be able to prevent it fully, but they might be able to reduce its impact. As the treatment progresses, we talk more and more about skills, about how do you recover your family relationships, because often they've been damaged by a manic episode or a depressed episode in one member. Let's say it's a couple for a moment, and it's a man in his 30s who's had the manic episode. His wife and he often need to learn to talk to each other again. How do we talk to each other now without bringing up bipolar disorder every other sentence? How do we get back the excitement we used to have in our relationship? Or can you talk to me without criticizing me? Can you ask me to do things differently instead of being hostile? So we work through these negotiation, communication, problem-solving techniques, and that actually takes a good portion of the treatment. We're now doing this with an app as well that reminds people to practice these skills on a day-to-day basis. I was going to show you a slide on this, what I call my career slide, the slide that shows my entire career in one slide. And what that slide showed basically was the results of 9 randomized trials that show that combining this family treatment with medications enhances the outcome of bipolar disorder. But I figured if I could summarize it in one slide, I could also summarize it in one sentence. So and that's the sentence that came out of this. So we do think this is an empirically supported treatment. We are trying to disseminate it wherever we can, but it's an uphill battle to get clinicians to practice this, to work with families. Many clinicians never bring in families. They see the individual or they run a group, but they don't think to bring in mom and dad, even if it's a kid. And to us, that's a critical component of treatment. What are we actually after here? Do we expect to cure bipolar disorder? Do we expect people to not be bipolar anymore? No, we have a fairly strict definition of what we consider wellness, a sustained period of wellness and quality of life despite the disorder. If any of you have ever attended a NAMI meeting, a National Alliance for the Mentally Ill meeting, you'll find this is very similar to the way NAMI defines recovery, which is a period of wellness and high quality of life despite having a disorder. When we're using this for research, we say a minimum of 6 months without impairing mood symptoms, and we also want to see good work, family, and social functioning. So a kid is both well, but also goes back to school, or a man in his 30s is able to regain his job or a job, and that the family is able to function. And we know that is possible, But we have to set that as a goal with the family early on. We're not looking to never have an episode again. We want your episodes to be further apart and your periods of wellness longer, but we also want your quality of life and your functioning to improve. Here are what I consider to be the core elements of managing bipolar disorder as a family. There are 10 principles, and although I won't go into them in detail, there's such things as learning to monitor one's moods. And here again is where an app comes in. We send people a text message every day and have them do a simple mood rating. You can do this yourself. There are many mood apps for bipolar disorder. We have them rate their sleep. We have them rate, how's your family doing on a given day. We have a robo voice that they call into and describe how they're doing, and the voice asks them questions about their family functioning in typical robo voice way. How are you doing today? That kind of stuff. Now, we collect all this information on a regular basis. That's one way simply of keeping data on oneself, and that's a common element of many cognitive behavioral therapy and dialectical behavior therapy techniques. Secondly, learning to recognize what are one's stressors. What are the stressors for you that tend to set off episodes? This is one thing that we've learned in the last couple of decades, is that bipolar episodes can be set off by both positive and negative life events. By positive, I mean suddenly getting a return on your taxes or getting into a new romantic relationship can be associated with an increase in manic symptoms. Likewise, a loss experience can lead to a depressive episode. Serious periods of family conflict are associated with more recurrences. We don't know who causes those. We don't necessarily care who causes them. We just know that the family environment is critical to keeping people well. But we need to know for each person what are stressors that appeared before the episode. Knowing one's positions on medications. Medications are a very high emotional topic. Most people with bipolar disorder do need medications in some fashion. We know that although many people say, okay, well now you can use fish oil or something like that, we know that those just are not as powerful as the standard psychiatric medications like lamotrigine, lithium, Depakote, antipsychotic medications. Those are effective, at least in controlling manic episodes and to some degree in preventing depressive episodes, although not certainly as strong as we'd like them to be. But we do want people to have a good rationale for why they don't want to take medications. And likewise with family members, you can imagine this scenario. You have a kid who's 13, say. Doctor recommends a drug like Lamictal, which is a fairly easy drug to take. It doesn't have a lot of side effects. However, only one of the parents in a split custody situation believes that the kid really has bipolar disorder. So the kid will go home to mom's during the week, and mom will give Lamictal out at breakfast and everything's okay, and then the kid will go to dad's house and not bring the medicines, and the father says, oh, you don't have to. You don't have to take those horrible pills over here. That's your mom's thing. Or you're doing that because you can't get along with your mother. And we, even if it's a divorced pair, we want to get these parents in the same room and have a common approach to the kid's medication use. Otherwise, the kid is going to go off at first available opportunity. So there has to be buy-in, in other words, at the family and the individual level. I'll say a word about marijuana use in a minute. Working on family communication, the way that families communicate has a lot to do with whether the environment facilitates recovery. Sometimes you can work with families to get reasonable accommodations at school or at work. Sometimes a kid needs an individualized educational program or a 504 plan, of which bipolar disorder There are such things for bipolar disorder, different changes that can be made in the school day or the school requirements. And that's one thing you can discuss or families can work on to make this an easier recovery. I also tell parents it's very important to take care of yourself. It's very easy to get sucked up by taking care of the child who has the disorder and putting everything else aside, one's own health, the other kids, the marriage, and really feeling when there's another episode that all has been lost. Very important for that person to have their own therapist, to have things like exercise on the outside, couples counseling if they're having trouble maritally, friends to talk to, something other than just taking care of this child. What about, let's say, a little bit more about medication adherence? I mentioned the scenario where one parent is advocating for medications and the other is not. Sometimes it happens that you have a parent who's giving subtle messages to the kid that they should go off medications. So we had a father who said to his son, you know, you used to be such a great basketball player. Now you go out there and you look like a spaz. And I think it's that Depakote you've been taking. In other words, I liked you better when you weren't taking medications. And kids hear that. It can also happen the other way around, of course. The kid doesn't want to take medicines and the parents are pushing it very hard, and the more the parents push, the more the kid resists, and that becomes the core of our treatment, is trying to at least get them on the same page about sometimes the kid has a very misunderstanding about the medication and what it'll do. It'll destroy my kidneys, it'll destroy my brain. I'll always be stigmatized by this. Some of which we have answers to. We know about the long-term courses of these medications and what impact they have. Sometimes it's a little more subtle. Ellen Frank and her colleagues talk about what they call the grieving over the lost healthy self. You probably won't see this in a young kid, but you might see it in a late teenager or an early adult who says, I used to have a good life before I got this diagnosis. I used to have friends, and I used to be athletic, and now I have to go to doctor's appointments and keep regular sleep-wake cycles and take medications, and it's all downhill from here. And sometimes they go off of their medications to try to prove that they're really the old self, not the new self. That's another thing we grab onto when we see it in treatment. Good sleep hygiene. For any of you who have teenagers, you know one of the biggest challenges of raising a teenager, period, is getting them to sleep regularly. They go to sleep with their cell phones right next to their head, and their friends are texting them in the middle of the night because their friends are always up in the middle of the night too, or they're playing video games late at night. And of course, teenagers need more sleep than they appear to. They wake up not able to focus the next day or not able to get out of bed. There need to be rituals around going to bed, even when the kid gets to be 15 or 16, putting the cell phones away, unplugging the modem if necessary. But the parents have to be models. They have to be able to say, I'm going to bed as well at this time. There's no reason you should be up later than me. So we work with families on putting together those kinds of quid pro quo arrangements. And if none of this is successful, there are online programs. There's one called Sleepio, put out by Oxford University. It's an online sleep regulation program. You have this little professor icon that sort of runs in front of you and gives you instructions on how to manage your sleep. It's a little bit old-fashioned, but it's well done. So that's another thing you can do. Okay, about that joint in your hand. This picture is supposed to be kind of a satire on the Sistine Chapel. Remember, the God's hand coming down and touching, only they're passing a joint. Why should we discourage marijuana use in young people with bipolar disorder? Because this is one of the biggest issues that we see in our clinic. Kids come in with smoking marijuana quite regularly. And they say, it helps me. It helps my anxiety. It helps me focus. It helps me socially. It helps me in every way to do this. And the parents sometimes saying, well, it is legal now. Is there a reason not to allow him to get high every day? Well, there are a couple of reasons not to. First, I have no moral qualm with people smoking marijuana. I grew up in the 60s, so I don't have a particular axe to grind about it. But I do think when we're talking about a disorder like bipolar disorder, it's dangerous. It actually is dangerous to be smoking a lot of weed and also be taking psychiatric medications at the same time, partly because the psychiatric medications won't work. They're just not as effective when they're accompanied by regular marijuana use. There is some evidence, actually, that cannabis use among adolescents is associated with both suicidality and risky sexual behavior. Risky sexual behavior, I think we would know about that because people get so-called horny when they smoke pot and they end up doing things that they wouldn't do ordinarily. But suicidality, I don't think many people think about that. It does tend to bring about these ruminative thoughts, negative thoughts that can get amplified while one is smoking or eating pot or whatever you're doing. It's not always the case that kids are self-medicating. That's the common argument, that is everybody who's using marijuana or alcohol regularly is self-medicating some underlying condition. And certainly there are people who are highly depressed or anxious who cope with it through using drugs. But it's also the case that these are teenagers who are looking to be with their friends, to do things with their friends that their friends are doing, to take risks, see what kind of person they are, and it may be part of that constellation rather than self-medicating, and then they get into the habit of doing it. So I wouldn't necessarily buy in right away to the self-medication idea. We have some studies that show pre-post cannabis use, some loss of memory and attention. So even though kids say it improves attention and memory, it actually reduces it by about 50%, at least over the short term. We don't know if it is helpful at all for anxiety. We don't know what dosages are helpful. And of course, there is the problem that what kids may be buying is not always the marijuana we think it is. It's got other stuff in it, PCP sometimes, other drugs. So we're not necessarily sure what they're eating and in what dosage. And finally, it does lead to sleep problems, especially if the kid is smoking right before they go to bed. So I think that's one that families need to take a stronger line about. Let me just say a word about borderline personality. How is this different from bipolar? Borderline personality is what we call a personality disorder. So by that definition, it should be a more constant trait, temperament, and interpersonal style of interacting. So with such things as emotional mood swings, outbursts of anger, fears of abandonment, unstable and conflict-ridden relationships, unclear and unstable self-image. All these things you could see in bipolar disorder as well. The main difference is they would be in episodes. So during a manic or depressive episode, you might see some of those things, but you wouldn't necessarily expect to see that between episodes when the person is doing well. Actually, the most recent literature on borderline personality suggests it's not as constant as we once thought, that there are people who seem to do better and have fewer of these symptoms with age, which is good news. In terms of how to tell them apart, in borderline personality, shifting moods don't reflect a change from the usual self in borderline personality. Borderline is, again, a personality disorder as opposed to a cycling mood disorder. Changes in mood are more rapid and short-lived in borderline personality. So you tend to see these explosive outbursts often when somebody feels rejected or there's some sort of a diminishing event where somebody has treated them badly and they fly into a rage. That's not the same thing as mania. By the way, if there's one thing I would definitely say, it's that beware of anyone who diagnoses your child as bipolar because of rage reactions. That used to happen quite frequently, that you bring your kid in because they're having temper outbursts where they break things and kick in walls and attack their siblings and kick the family dog, and they were given diagnoses of bipolar disorder. We know that's probably not bipolar disorder in most cases. It's often ADHD combined with anxiety and oppositionality. Sometimes there's autism spectrum involved, but bipolar would be pretty far down the list. So now, borderline personality we don't usually diagnose in 13, 14, 15-year-olds. It's usually more when people get to be adults and start having dating relationships and so forth. But believe it or not, you can have both of these disorders. And watch out if you do. How do you tell it from ADHD? The easiest way to tell mania from ADHD is by the presence of so-called prototypic symptoms of mania. So decreased need for sleep, flight of ideas, elated mood, grandiosity, hypersexuality are all very rare in ADHD, whereas they're fairly common in bipolar disorder. So in other words, if you have a bipolar kid in a manic episode, they're going to show signs like decreased need for sleep. That's when you can really tell whether it's ADHD or not. What doesn't help very much are these symptoms: irritability, speech rate, how fast they speak, and their distractibility and energy levels. Those can be high in either disorder, and that's the cause of the diagnostic confusion, is because of when people are hyper in their behavior and energetic and distractible, that can look like either mania or ADHD. How am I doing on time? Are we doing okay? Okay, yeah. Last topic I wanted to talk about was creativity. What about this link between bipolar disorder and creativity? Is it true? And if so, what do we know about it? It's not the easiest thing to investigate systematically. If you look at Kay Jamison's work, Kay Jamison is a psychologist who herself has bipolar disorder, wrote some very influential books, including one called Touched with Fire, which was about various writers and artists and musicians who had bipolar disorder. These are the people we think had manic episodes during their life. If it says SA after them, that means they made a suicide attempt. If there's an S after them, it means they died of suicide. And if there's an H, they were hospitalized for psychiatric reasons. So Hermann Hesse is a good example, hospitalized, made a suicide attempt. Fitzgerald, we know that he had alcoholism, but he was also hospitalized for a suicide attempt. Ernest Hemingway had both and died by self-inflicted gunshot wound. So a portion of these, maybe not all of them, but a portion of these probably had manic episodes. So there is some evidence that at least writers who were creative have been afflicted by this illness. It's also true of composers, and it doesn't seem to matter what kind of music the person's writing, because on this list is anyone from Handel to Kurt Cobain, all of whom had bipolar manic episodes, and several of whom committed suicide as well. So this does seem to haunt the very talented, creative people. One question that's been raised is it just the kind of artistic temperament, the sort of explosive, I've got an idea and staying up all night for a couple of nights to write a symphony and then crashing for a week at a time like Beethoven presumably did? Is that really bipolar disorder, or is that a cycle of artistic temperament? We don't really know, except that they were treated for these conditions as well. What does the research actually say? A couple of things. Creativity is higher among bipolar people than among controls. Non-psychiatric controls is a term that really means normal people. So creativity is higher. How do we measure creativity? There are a number of ways, but one way is to one of those tests that says, okay, come up with 15 uses for a brick. And you're supposed to list what are the uses of a brick. And if you think about it, well, there's, building a house, there's holding down papers on a table, and then there are people who say, well, grind it up and add some oil and you've got paint. So some people would say it can be used as a writing implement. So there is this idea of being able to generate a lot of ideas, a lot of associations. And bipolar people do better than that. Better on that kind of test. There are people in creative professions like writer and musician are more likely to have bipolar disorder than people in healthy groups. Interestingly, creativity is higher in the first-degree relatives of people with bipolar disorder, whether or not those relatives have bipolar disorder. In other words, if you look into that pedigree idea, you could find someone with bipolar disorder, and they may or may not be creative, but you will find people in the family who have creative professions, like writing, art, music. So there is something that we think there may be co-segregation of genes that occur that are both related to creativity and mood instability. We really don't know. But from a clinical point of view, the most practical point I find to take away from this is first encourage people who have artistic talents to use them as a way of expressing their inner pain, perhaps. But also, creativity seems to be more linked to hypomania than mania. Remember, hypomania is that less intensive form of mania that's not as functionally impairing. So when someone's hypomanic, they may put together wonderful pieces of writing or music. When they're fully manic, you see them put a lot out, but it doesn't make any sense. It's either writing that makes no sense or music that's very discordant, lots of it, but not anything that they're ever going to come back to or use. Or they make big charts of how things are connected in the world. So it's if the person can maintain some healthy hypomania, which may mean some negotiations with the doctor about medication dosages, and there are ways to do that, they may be able to keep their artistic output without having to be unstable in their bipolar disorder. That's what we would like to see happen. So a couple of promising new treatments coming down the pike. There are medications like lorazepam. Ketamine is one, although you may recognize it as a street drug. It's a drug that's being used with treatment-resistant depression. It's an anesthetic. There are certain ways to take it, but people do come out of severe depressions rather quickly. Aripiprazole is an antipsychotic. Lamotrigine is an anticonvulsant. I mentioned family-focused therapy already. Dialectical behavior therapy, which is a treatment that teaches people emotional self-regulation techniques and mindfulness, for example, meditation. Mindfulness-based cognitive therapy, which is done in a group. And internet-based psychoeducation. And I just want to say a word about that in relation to AIM. Both Mark Weintraub, my postdoc, funded by AIM, and I are working on a study to try to take these ideas I've just been talking about and appify them. By appifying them, I don't just mean you can go to a website and click and find out where these slides are or what to do when there's a manic episode. There needs to be a constant interchange between a person in a family or with a disorder and the circumstances in their life and what they can do under situation X, Y, or Z. What skills are available to them? How do they identify their episodes? There needs to be a way for them to express what's going on with them. And that's why we have those robo-voice calls. So it's truly an interactive app that we're trying to develop And people are liking it so far, particularly the call-in feature, where people can just call in and say how their day is going, which for some parents who are feeling socially isolated is a big addition to their day-to-day life. They don't have that elsewhere. So I think there may be more and more room in the future for internet-based approaches. We have to remember that they aren't replacing person-to-person care. They're meant more right now as an adjunct to regular psychological care. So take-home messages: bipolar disorder is highly recurrent and disabling. Many of the stressful effects of bipolar disorder fall to parents and spouses. It's very difficult to be a parent or spouse under those circumstances. Bipolar disorder can be treated in recovery with optimal combinations of medications and family, individual. I didn't talk much about group therapy, but there's a role for group therapy as well. We know illness management skills such as taking medications or sleep regularity or tracking one's mood can contribute to recovery. And once stabilized, people with bipolar disorder often make highly significant contributions to society. That's the good news, I think, that we have treatments that can help people stabilize, and when they do, they may very well make a good contribution to society. For all you caregivers out there, remember, take care of yourselves. You'll be helping the person with the bipolar disorder if you do that. So, another shameless self-advertising. This is our book for families, Bipolar Disorder Survival Guide. And I'll end with a quote from Kay Jamison, who says, "I cannot imagine leading a normal life without both taking lithium and having had the benefits of psychotherapy. Ineffably, psychotherapy heals. It makes some sense of the confusion, reins in the terrifying thoughts and feelings, returns some control and hope and possibility of learning from it all. It is where I have believed, or have learned to believe, that I might someday be able to contend with all this." So I want to thank AIM once again, and I wish you all luck. Thank you.
Wow, extraordinary. We are going to break for a few minutes, but I want to remind you of a few things. If you have friends, colleagues, family members who can't be with us today, you can pick up perhaps the most exciting part of today's program on our social media platforms. So Facebook, we're at AIM Youth Mental Health, and Instagram and Twitter at AIM Mental Health. And you can just click on the link there, and we're going live. We are accepting questions to the doctors during their panel discussion coming up on all of those platforms. So thank you for that. I want to segue to our next, to the next stage of today's program, but I want to give you a couple of things. First, we refueled with coffee. That's really important. And you caffeine fiends have depleted the first round, but we got you covered. So refreshing, we've got some snacks out there. Talk to your community members, your colleagues about what you've learned today. Collaborate on your questions and stimulate your creative thinking. And I want to open up the floor to Susan Stillwell again for a couple of minutes to share some really exciting things that are coming up on AIM's calendar.
Thank you. I know it's a long morning, but I think the speakers have been amazing. I'm very inspired. But I want to remind you all that AIM is a very positive, fun, we want to be a fun campaign if possible with a very serious subject. And so I just wanted to tell you quickly about the three main events that we have that are fun this year for if you have any interest in getting involved. We are always looking for volunteers. We have our annual AIM for Awareness Walk and Rally at Lovers Point on September 15th in Pacific Grove. We are hoping to get teams signed up. You can go ahead right now and sign up a team and then have people join you. You can also sign up as individuals. The walk and rally will have games for little kids up to young adults. We will have speakers. If anyone is interested in doing any performance there, let us know. Last time we had the rally, we had dancers, we had singers, we had people with personal stories, so it was a fun event. We also have our gala in Pebble Beach. That's August 15. We are this year making the gala more into an entertainment rather than a charity dinner. We are having the 4 Phantoms in concert perform. It's essentially a Phantom of the Opera performance by 4 of the top Phantoms from around the world joining together. I don't know if you're familiar with Phantom of the Opera, but Christine is the woman in the performance, and they bring in whoever is playing Christine on Broadway from New York to Pebble Beach for this event on August 15. It's going to be a fantastic performance. And then finally, we have our Aim for Awareness ad contest for middle and high school students. We've had tremendous results in the past, and kids love it. It opens up conversations in the classroom. It provides a project for teachers without them having to figure out something to put into the curriculum to start the conversation with mental health. And kids really express themselves through this project. And it's not just for art students, it's for every student because, as you know, ads don't have to be art. They can just be one word or anything on a piece of paper to get attention. So I hope that everyone will take advantage of that if you are involved with middle or high school students. Thank you so much.
Thank you. So let's take a short break and let's reconvene at 11:40, so 10 minutes. See you there.